A very good evening, everyone. On behalf of the IIP Digital team, I, Dr. Manisha Tarpalikar, welcome all of you for today's event. First of all, let me take this occasion and let me wish all of you a very happy World Physiotherapy Day. To celebrate this day, the Indian Association of Physiotherapists Thane District Branch is conducting a webinar on overview of role of physiotherapy in diabetic patients and starting a diabetic clinic in the physiotherapy setup. This is the first webinar conducted by this newly formed Thane district team. Congratulations to this team. The speaker for the webinar is Dr. R. Arunachalam. Sir is a professor and head of the department at the College of Physiotherapy, Madhav University, Rajasthan. The moderator for this session is Dr. Nikita Gadge. We are live streaming on the official IIP India YouTube channel. I request all participants to subscribe to this channel to receive updates and to view upcoming webinars. If the participants have any questions for the speaker, I request them to kindly put them in the chat box. These will be answered at the end of the session. I now request Dr. Nikita to kindly take over. Thank you.
Thank you, ma'am. Good evening to one and all present for this webinar organized by the Indian Association of Physiotherapists, Maharashtra State, Thane District team. Today, the 8th of September, is a very special day for us, being in this noble profession, whether be as a student, a graduate, an academician, a researcher, or a clinical practitioner. We proudly acknowledge this day by celebrating as the World Physiotherapy Day, as the World Confederation for Physical Therapy, the WCPT, was found on the same day in the year 1951. We are celebrating the 70th year of World Physiotherapy. This day celebrates the unity and solidarity of the global physical therapy community. It is a chance to recognize the contributions that physical therapists provide to their patients and the community. And on this special occasion, we, the Thane district team, have got this wonderful opportunity to launch our team with its first event. To begin with the event, I would like to take this opportunity to thank the IIP Central team, Dr. Sanjeev Jha, Central President, Dr. Suresh Babu Reddy, Vice President, Dr. A.M. Annamalai, General Secretary, Dr. Ruchi Vashne, Treasurer, Dr. Joji John, National Head Branch Coordination Committee, Dr. Nehal Shah, Joint Secretary, West Zone, Dr. Sudeep Kale, West Zone CEC, Dr. Achal Vashi, West Zone CEC. And now, I would like to warmly welcome the major support system for us district teams, the dignitaries present for the webinar from the Maharashtra State team. Dr. Ujjwal Yevle, President, Dr. Amit Gire, Vice President, Dr. Bharti Dave, General Secretary, Dr. Darshana Trivedi, General Secretary, Treasurer, Dr. Mansi Mehta, Joint Secretary, the EC members, Dr. Sohan Selkar, Dr. Sanjay Rajhans, Dr. Rahul Deshmukh, Dr. Asmita Moharkar, Dr. Suvarna Ganveer, Dr. Suraj Kanse, Dr. Uttara Mohan, and Dr. Snehal Patel. We welcome you all. Now, I would like to request Dr. Ujjwal Yevle sir to please address the event.
Thank you, Dr. Nikita. So, first of all, wish you all physios, the Thane district team, all EC members, the participants, the resource person, a happy World Physiotherapy Day. Dear colleagues, just to begin with, as all of us are well aware that like other professionals, all physios also during last 1.5 years, clinicians, academicians, all also have tried to sustain themselves and have worked upon so as they have come up with the new ideas, re-establishment, okay, and then further working on setting up their own clinics. So there are many new ideas which are coming up, which include collaborations with the consultants, joining hands with other healthcare professionals, and so has It's, complementing even the physios who are working in the same area. I'm really happy that Thane district has come up with this innovative topic for the discussion. There's a new and a big scope of physiotherapists who are working in the diabetes. India, and in fact the whole Asian countries are considered to be the capital of diabetes. So there would be the maximum people all over the world when we consider India or the Asian countries who would be suffering from the diabetes. So in fact, there stands a big role of exercise, fitness, then lifestyle modification to prevent the diabetes to happen, as well as to prevent the further complications of this condition. So I'm really happy and congratulate Thane district for organizing such a nice event. And I'm very sure after attending this webinar, many of the physios would start with physiotherapy setup, especially for diabetes clinic. So thank you. Thank you all for having me here. Thank you so much.
Thank you, sir, for your kind words. I would now like to call upon Dr. Bharti Dave ma'am to speak a few words.
Good evening to one and all, and wish you very happy World Physio Day on behalf of entire Maharashtra team. It's my pleasure to talk about today's event, as this is one of the different topic, what I could say, and really proud to have such a strong team who have in short notice arranged different topic and really useful one for all of us. I hope this is going to get a new platform for all of us to add on in your clinical practice and establish more firm with our patient treatment. Good luck to this team. Nikita, you want me to introduce your team, Thane district team? Thane district team.
Yes, ma'am. Yes, you can go ahead with that also.
Nikita was very excited that ma'am should announce our names, so I don't mind, as this is my favorite team. All are my favorite, but yes, y'all are known to me and y'all are working very hard. So proud of all of you and congratulations to one and all Thane district team. To start with, we have Venkat Ramesh sir, convener, Dr. Jay Pathak as secretary, Dr. Pratiksha Dige as treasurer, and our EC members are Dr. Suraj Shukla, Dr. Nikita Gadke, Dr. Gaurav Tripathi, Dr. Swapnil Mate, and Dr. Ravi Prakash Singh. So these are all a team of Enthu people who have joined to form a strong Thane district team. So welcome you all on the board and congratulations to all the team members. And today's message to one and all, whoever is hearing this topic, I'll advise do not leave incomplete, because many more things at the end of the session will be announced. And good luck to you all. And without wasting the time, over to you, Nikita.
Thank you, ma'am, for your inspiring words. This means a lot to us. And we definitely, as a team, promise you to withhold this trust and opportunity given to us by the central and the state team and work in the best way we can. I would now like to request Dr. Darshana ma'am to speak a few words.
Hello, good evening, everyone. First of all, thank you, Dr. Nikita, for the introduction. And thank you, Thane district, for calling me in this as a panelist. This is actually a very nice topic, and myself being a clinician, I would actually love to be in this webinar. And thank you so much for this, and all the best, Thane district team. Okay, thank you so much.
Thank you, ma'am. Now we go ahead with the webinar and welcome our respected speaker, Dr. R. Arunachalam sir. Dr. R. Arunachalam is presently designated as Professor and HOD at College of Physiotherapy, Madhav University, Rajasthan. He has pursued PhD in Physiotherapy, Masters in Neurology, PG Diploma in Diabetic Education from CMC Vellore, Fellowship in Diabetic Education, MSc Yoga and Naturopathy. We welcome you, sir. Over to you.
Am I audible, ma'am?
Yes, sir.
Very good afternoon good evening to everyone. This is a very auspicious day, and I hope this is a very busy day for everyone. But I'm so happy to be in connect with one of the pioneers in the field of physical therapy, Dr. S.V. Ramesh, sir. And I really congratulate the Pune district team, IAP team, for organizing this program. Actually, organizing this program, every program nowadays, it's become very easy because in Zoom platform, if you catch up an resource person, you can go with that topic, not an issue, but you're handpicking the topic. That is very important. So Dr. Ravi Prakash and Dr. S.V. Ramesh, sir, both of them were very particular about this topic because they were highly impressed and they wanted to give what they perceive to be best topic for their predominantly clinician population. So I congratulate everyone who is associated here. Dr. Jay Patak, Dr. Bharti Dave, Dr. Ujwal, Dr. Suraj, Dr. Pratisha, Dr. Nikita, Dr. Gaurav, Dr. Darshna, and Dr. Swapnil and Dr. Nikita. So I have read through all the names because you have all put your hands up in conducting this program and making it a grand success. Thank you so much. And I sincerely apologize to the organizers for my delay and the inconvenience. Actually, I had come over nearly 400 kilometers away from Chennai to attend one physical program, which is happening after 2 years in our place. So it was wonderful meeting the students, and really I was not able to finish my talk with the students. So it has stretched for another 15-20 minutes. I sincerely apologize for that. So without wasting much time, I would like to share my PowerPoint. Can you please tell me whether it is visible?
Yes.
Thank you so much. So our topic today is diabetes educator, diabetic educator, which is highly needed in the future for Indian community. I am going to tell you in this short talk about what is the need for the diabetic educator, who is a diabetic educator, and how physiotherapists are fitting exactly into this bill of diabetic educator, and what is the future for this. Fine. So when it all started, when I came across this program, which was conducted in Christian Medical College, which is a very prestigious college in down south. It is in Vellore district. So when we came to know about diabetic education and diabetic educator program, we all were taken by surprise. What is this actually? How physiotherapists are eligible for this? But now actually, if you see, CMC Vellore is doing this program only for MBBS students, MBBS people who have completed MBBS. For them only this is eligible. They have stopped doing this for physical therapists. I don't know what is the politics behind that, but we are the exact person who fit into this bill of diabetic educator, and we can very easily open up a diabetic clinic of our own if we have some basic amenities. So that is what I'm going to discuss with you now. So in my previous college, we did a study where we asked physiotherapists to prioritize their aims, problem list aims and treatment for a given scenario. So we did this cross-section study to know whether physiotherapists are prioritizing glycemic control in the management of musculoskeletal problems of type 2 diabetes mellitus or not. So this is what our main aim was. So then what we did was we gave a case scenario where a 49-year-old man presenting with severe low back pain for 3 weeks duration. He is unable to bend forward, severe burning sensation on his foot, presenting with left lateral trunk shift. Okay, so these are all illusionary words which we used, where physiotherapist will be more diverted. And we also inserted a small word like HbA1c was 9, and tenderness over the L4, L5 paraspinal muscles, weakness of bilateral hip abductors, extensors, and spinal extensors. So we asked all the physiotherapists, somewhere around 300 physiotherapists, to devise the problem list, the aims of their management, and what is the physiotherapy intervention they will give for this particular patient. So they have to give 3 points. So it was very surprising to see for us that nearly more than a quarter of the patient only, less than a quarter of a patient only came up with prioritizing the glycemic control. And majority of them did not even mention this glycemic control in their uh, treatment or in the problem list or in the aims of the management. So the numbers are missing here because I'm logged into to a different computer. So the numbers was 28% prioritized, sorry, 18% only prioritized glycemic control, and the remaining whooping 82% of the people did not prioritize glycemic index at all. So this gives you a clear idea that for a physiotherapist, these tenderness, pain, weakness, numbness, postural corrections, these are all the priority, but not the glycemic level. And we have to understand that if the glycemic control is not achieved, the peripheral neuropathic symptoms, either it's sensory or motor, it is not going to subside. So our success of treatment mainly is revolving around this glycemic index. So that we have to understand first of all. And with this basic introduction, this research, I understood that most of the physiotherapists are not worried about diabetes. So why diabetic educator now? What is the role of a diabetic educator? What basically you have to do to become a diabetic educator? First is your knowledge and awareness about diabetes should increase. We all know that diabetes is an increased glucose level in the blood, okay, circulating glucose level. What are the complications? What are the microvascular, macrovascular complications? How it can delay the wound healing? How it can bring about pain perception, what its role on the descending pain suppressing system, how it irritates the nerve endings and causes illusionary pain, what is the role of diabetes in the central sensitization of pain, all these things we need to know. Okay, so when we know all these things, first hand, we will know what is the role of diabetes and glycemic levels in the management of pain-related physical therapy and paralysis in physical therapy. So we will know that first we have to attest to the diabetes. Next is uh, we are going a step ahead of what we are currently providing physical therapy to patients, and we are going one step ahead in a better physical therapy delivery when we attest to the diabetes part of the patient. So you will be showing yourself as a different person, a different physical therapist from the other physical therapists, producing result not region specific. So you might have seen patients who are coming with shoulder pain. After 3 months, they'll be coming with knee pain. They'll be coming with back pain. So this is it's not a region specific scenario when it comes to diabetes. It is a holistic approach what is needed for them so that they don't recur with pain. And also if you attest to the diabetic part of their treatment, you're going to attain a better cardiorespiratory endurance, and their quality of life is going to be enhanced by that. And the doors are opening for physical therapists as a diabetic specialist centers, and you can play a dual role. You can play a dual role. On Sundays, you can be a diabetic educator, and on the other days, you can be a physical therapist. And your contribution to the society, your contribution to your patients, and your reputation is going to increase. So this is a very good opportunity. And last but not least, you can be an entrepreneur. You can be a better entrepreneur than many people. Of course, money is essential for everybody, and this is one way of earning a much better income compared to adopting some pseudosciences and taking up short waves. And you can be a better entrepreneur. You can own a diabetic clinic, and you can employ many professionals in this. you can what to say, you can showcase your talents and you can showcase your profession in a much better way. And I feel this is the best day for me to present about diabetic educator dimension of a physiotherapist on a physiotherapy day. And I'm really thankful to the Pune team for this. So what is the latest projection? So whenever you're going to start a business, first thing what you will see is what is the scope for this? What is the need for this? That is what we always think about. So for that, what we will do is there any demand for these goods? That's what we always see when we are starting up a clinic, a business. So in this clinic, is there a demand in the future for a diabetic educator? So let us see what the WHO, the highest health body of the world, is going to say. Uh, the forecast is like, see, in the Southeast Asian countries, the levels of diabetes is going to jump leaps and bounds in 2020. Okay, so in 2000 it was 176 million, and in 2030 it is forecasted to be 370 million. So this is a worldwide scenario. So what about the country-wise scenario? If you see, India is leading currently, as well as in 1995 also India was leading China, which has a marginally better population than us. We are leading them a marginal ratio, but in 2025 the forecast says that this gap between India and the second country is going to increase, and India is going to become the capital of the diabetes population. So this is an alarming situation in India, and we are already the capital of diabetes, and we are going to further worsen. This is the world map which shows the distribution of diabetic population in the world, where we fall in line with most of the developed countries. In developed countries, the management has become much more stringent and they are adopting a better option, because this diabetic educator has evolved a long time back. Why I'm saying this diabetic educator alone is, it's a strategy that has been worked out successfully in most of the countries. Now we are slowly catching up with that. And if you see, India is in the more than 12% of the population is already having diabetes. And if you see all over the world, what is the distribution? 69.2 million Indians are having diabetes, which is far more than the other countries. And if you see in India, every 1 person in 11 adults have diabetes. This is one scenario that is alarming, and the second scenario is even more alarming. That is, out of 2 diabetic patients, 1 diabetic patient is not diagnosed yet, so he is underdiagnosed. Normally, in Indian scenario, we diagnose diabetes only when we go for an master health checkup, or suddenly there is a surgery, you go for a blood checkup. Randomly, you check blood one day, you find out you're diabetic. So, underdiagnosed people are more, and they're equivalent to already present population. That means we have a double amount of diabetic load in India. Whatever is, for example, you see now it is 69 million, means we almost have twice that. So that is a problem in the future as well. So this is the number games we are seeing. So now what is the medical expenses? Because that is what very important, right? So the direct cost and indirect cost of diabetes in 2007, 2012, and 2017, if you see, the direct cost is increasing. The direct cost of people spend on diabetes and diabetes management is increasing. So it's a potential area for medical workers to invest their time and their clinic into. Just change the direction of the clinic, you can earn more because more money is involved here. So don't think that I am talking from a monetary perspective, because that is also required for us as an entrepreneur. That's when we can serve the community better. Of course, this is a service industry, but we are charging our patients and we are charging for a good quality service. That is what I just meant here. And if you see, if there is a complication, if the patient is not having any complications, the medical expenses are less. But in case if the patient is having microvascular complication, the expense becomes double. If he's having only macrovascular complication, again the expense is increased. And if the patient is having both microvascular and macrovascular complication, the medical expenses is increasing leaps and bounds, and almost 3 times it increases. So from here, what we understand is the diabetic educator can concisely reduce the complications in these diabetic patients, and he can save the patient's money. Though he's earning from diabetic patients, he's stopping them from going into complications. So in that way, it is a benefit for the patients, without any doubt. Okay. And these are the number of times the expenses increases. Now, if you see these numbers,
Sir, you're muted. Unmute yourself, please.
thank you, sir. So, what is borderline diabetes? We have the fasting and postprandial blood glucose level. If the blood glucose level goes, fasting blood glucose level goes beyond 126, we call them as diabetic. Or the postprandial, if it goes more than 140, we call them as diabetic. But in case if the fasting is between 120 and 126, or the fasting is between 140 and 200, then we call them as borderline diabetic. It is otherwise called as impaired glycemic control, impaired glucose tolerance. Okay, so in this scenario, these are like a cat on the wall. People who are sitting on the cat, like a cat on the wall. They can either become diabetic or they can become non-diabetic.
Sorry to interrupt. Sorry to interrupt, sir. Could you please be a little louder? I think there are requests coming from the participants.
Okay.
Yes.
Is that okay now?
Yes, sir. Yes.
Okay. So these people are like a cat on the wall. They can become diabetic in the due course of time, or if they take invasive measures, they can become non-diabetic also. So what matters here is the time duration at which they have been diagnosed as pre-diabetic, and what they do after they have been diagnosed as pre-diabetic, whether they are going for a rigorous intervention or they are going to ignore this, expecting that to become normalized. That in this COVID scenario, this is a big headache for most of us. Okay, so now this pre-diabetic patients can be converted into a non-diabetic patients by means of proper counseling and by means of proper guidance, which is provided by the diabetic. So here also the diabetic educator plays a very vital role. Now, so this is the ratio of diabetes and pre-diabetes ratio that is present in India among 30 to 39-year-old male. If you see, people, if you see, the pre-diabetics are more. So here, if we control this pre-diabetic properly and monitor them properly, over a period of time, the people who are getting converted into the red zone, that is the diabetic zone, will be diminished. So it is better to go for an early intervention or early attention to these people. So as the age progresses from 60 to 69, if you see in 69 years, only 20 are pre-diabetic and 41% are being diabetic. So that says clearly that at the early stage, that is 30 to 39 years, proper screening and education about diabetes is very immense. People who are walking to pain clinics are predominantly pre-diabetic. So that is a statistics which says. So who are the first visit practitioners and first contact for them are the physiotherapists. So we are in the correct position to screen these pre-diabetic people. So the high prevalence of glucose intolerance is even very common in South India. That is very young adult, the people who are going to school. This is the scenario in 2007 where school students are also diagnosed to have diabetes and heart diseases. It is very heartening to know, but it's very clear that this is not only a scenario in South India after 10-15 years, it is also catching up with tribal villages like in Arunachal Pradesh, Manipur, Mizoram, and the trend is not clearly understood in India. There are two states which are close by, Manipur and Mizoram, Manipur shows more number of diabetic patients, whereas Mizoram shows less number of diabetic patients. But what is heartening is these tribal areas where people are living with nature, who are having a very good access to good natural food substances and pollution-free ambience, are still susceptible to diabetes. So it is very difficult to understand how these people are also exposed to diabetes. So what are the common beliefs which are myths, that is, which are proved wrong? The first thing is high body mass index. People who have diabetes will have high body mass index, and they will be predominantly urban origin. So that is a myth, because it is proved from the recent studies that there is no disparity between urban population and rural population as far as India is concerned in case of prevalence of diabetes. There is a very marginal difference between them. Second, even if you are a lean person, you are susceptible to diabetes. There is no link between the body mass index and the diabetes. So we call some people as toffee, that is thin outside and fat inside. So they are called toffee. So there are toffee people who are also diabetic. So this is a myth. Next, mainly a problem in the South India. No more. This is not a problem of South India, because people say that you are predominantly rice eaters, and North Indians, we eat a good amount of fibers, so we are not vulnerable for diabetes. But I'm very sorry, the distribution of diabetes is predominantly south. It's not between South and North. Only Northeast states are coming up with less number of diabetes. Otherwise, the Northeast, Northwest and South all are rated similarly. Doctors are the key to the management of diabetes in our country, which is a big myth that is not true. What is the role of paramedics is being very clearly mentioned nowadays, and we can play a very vital role, which is equivalent to a doctor, that is a physician or a diabetologist, in the management of diabetes, because doctor alone cannot manage diabetic load in India. So that is very much clear. So normally what the physiotherapists do is, when you have diabetes, you go and contact a physician. He will direct you to about the medicines and the exercises and everything. You come for only the exercises. That is what normally we adopt. That is the situation now, but that is not going to be true anymore if we become a diabetic educator. And this is a very important thing. How often we give knowledge to the patient about diabetes. Patient self-empowerment is a mantra by which all the developed countries are limiting diabetes numbers, which India is not doing. Maybe because of lack of medical people who can spend some time with the patients, or the literacy rate of India. All these things will contribute, but somebody has to take the first step to curtail this situation, right? So let it be the physiotherapist who can do that. And this is the right day to know about what is the first step we can do in this. Type 2 diabetes is a disease largely governed by genetics. There are no other co-factors. If you think like this, then that is absolutely wrong. You have environmental factors, you have birth weight as a factor, you have your food habits as a factor, your lifestyle as a factor, stress as a factor, and a lot of hormonal imbalance as a factor, activity as a major factor. So you can't say that I got diabetes because my father and mother got diabetes. Yes, you are susceptible to diabetes if your parents are diabetic, but it is not that you can have a quality of life if in case you have diabetes, or you will definitely inherit diabetes from your parents. If you think so, then that is wrong. And if someone says I have completely cured diabetes, so far it is not being proved that diabetes is completely curable. One case or two cases here and there which have been misdiagnosed to be diabetes have been cured, have been claimed to be cured, but so far there has not been any solution for diabetes as of now for a complete cure of diabetes. So don't run behind. You have to warn your patients that they should not run behind these Unani, Ayurveda, Siddha. Yes, they are all good medical system, but there is no solution for diabetes as of now yet. And also a lot of cultural tantras for reducing this diabetes or blood glucose levels, dietary solutions. Nothing is going to work apart from the triad of treatment of diabetes, that is exercise, diet, and medication. Now, you all would be wondering where is the what is the role of the diabetic educator here, and I would like to tell you that in current scenario, a patient will directly go to the physician if he is having diabetic problem, and the patient will refer him to the laboratories. Once the laboratory report comes, he will ask him to take up some medication, and the patient will go to the pharmacy, and then he'll take the pharmacy service and he'll go home. So the physician is not going to instruct the patient whether to have the medicine before the food, along with the food, or after the food, how to put the insulin injection, what are the complications you have to look into, what are the side effects of the medications. Nothing is going to be taught to the patient. So the patient empowerment is absolutely nil in this sort of a conventional system of patient referral and patient treatment in diabetes. So what is the solution? What is the system adopted by the Western countries, the developed countries in management of diabetes is they adopt something called the physician will, after referring the, after consulting with the patient, he will refer the patient to a diabetic educator. The diabetic educator will spend 6 hours to 10 hours in evaluating the patient, particularly about the diet, what are the taste of the patient, what he's already taking, what are the physical activity he's doing, how to, by grading the physical activity, what are the complications currently he's having, and very importantly, what is his idea about diabetes and what is his idea about where he's going to progress from here on. Okay, because nobody is going to give the reassurance to the patient in this current system, but in the new system of referral, the diabetic educator is going to empower the patient with knowledge. So once the patient is being empowered with knowledge and he is not being threatened, he 1 minute. Yeah. If he's not threatened about diabetes, his perception about diabetes is going to change. Once his perception about diabetes is changed and he understands what is actually happening to him is not a disease by itself, it is a metabolic status. And if he do something, he will land up in good status. If he doesn't do that, he is going to worsen. So if this option is given to the patient, definitely every patient would adopt the proper do's and don'ts from there on. Instead of that, our current medical system, what it does is, sir, you should avoid rice, you should walk daily, as if there is no other exercises available for diabetic patients. We normally give them the ideas which are old and myths and which are outdated knowledge. So the diabetic educator is a person who is a fulcrum of the diabetic rehabilitation. After spending so much of time with these patients, he's going to refer the patient to the diet counselor. He's going to refer the patient to the physical therapist for exercises. He's going to refer the patient for ophthalmic examination in case if it is needed. He's going to send the patient to the foot care specialist if there is a need. And he's also going to send the patient to the orthopedician or a neurologist or a gastroenterologist whenever it is needed. And by doing so, after doing all these things, he's going to report it back to the physician. The physician may be a diabetologist or a simple MBBS physician. It's all how you recruit them for your diabetic clinic. Here, in my clinic setup, I have recruited a physician who is a diploma in diabetic management, and he's a very kind-hearted person and he's a very cooperative person. Um, and I will report him back all these reports if it is needed. So in case if there is no need for an ophthalmic examination, I find this patient is not having any functional problem with this, and after I'm examining the eyes, eye fund and everything, I don't have any problem with that. I'm not going to refer the patient to the ophthalmic examination. So thereby, I'm conserving some the cost incurred for the management. In case if I examine the foot and find the sensations are normal and there is no wound, there is no alarming signs for an amputation or a diabetic neuropathy, I'm not going to refer the patient to the foot care specialist. So the diabetic educator becomes a fulcrum along with the physician and he is going to spend more number of time with the patient. Okay, so this is also in the pipeline. The India becoming the headquarters for amputation, and amputation, we have a very effective role to play in amputation, both in prevention as well as in the management. Okay, now coming to the last section of this presentation. I'm not able to give you everything in one session, so I'm just giving you a nutshell of all the presentation, or the build up of a very good course which can be held for somewhere around 20 to 25 hours. So 7 points for a successful diabetic clinic. So now I will tell you that there is a need for the diabetic clinic, and I have proved that physiotherapists can be a very good diabetic educators. What is the role of the diabetic educator, and what are the 7 points of a successful diabetic clinic? Now, first is be thorough in diabetic mellitus. Each and everything you should know. You should know how to assess the eye. You should know how to assess the sensation. You should know how to assess the complication, the symptoms of complication. And this will not come only by means of reading and it will come with experience. So, experienced physiotherapists are the initial stakeholders for a diabetic clinic, and they can very successfully run that. Okay. Next is a diabetic clinic should function at least once or twice in a week. For example, if you have a physiotherapy clinic right now, you can, my clinic is on leave on Sundays. So what I have converted initially was my physiotherapy clinic was functioning as a diabetic clinic on Sundays. Okay, and I was not there. It was taken care by some of my friends. But you can be a diabetic educator on Sundays. Later on, you can increase the number of frequency of days, twice or thrice. Most of the physiotherapy clinics do not do a very good business in the morning time. That's what I have understood. So you can convert in the morning time, 2 or 3 days, you can convert it into a diabetic clinic. Or concurrently, physiotherapy as well as diabetic education program can happen in a clinic if it is sufficiently large. Next is ensure that laboratory is in good shape. You need to invest at least 80,000 to 1 lakh on laboratories. One processor can do most of the basic diabetic analysis. Okay, so it comes around 80,000 to 1 lakh. So that processor you can buy. Maybe a good company like a Siemens or a Bayer's company you can buy, and you can employ one laboratory assistant who can visit your clinic only on particular time to analyze the blood samples, or you can adopt on-call services. Or initially what we did was we took the blood samples and we send it to the nearby laboratories. But I always recommend you having a laboratory at your clinic with a minimal investment. If you see, extracorporeal shockwave therapy cost around 5 lakhs, but a full-fledged basic community of a laboratory will cost less than 2 lakhs. So you can invest on that. Ensure that essential and cost-effective drugs are stored in your place. If a physician is coming, you can store some basic medicines there. So that you can do, because for dispatching the medicines, immediate supply of medications, insulin vials for patients. It becomes a business for us also, because there is a good amount of what to say, profit for the physiotherapist if you are selling insulin and the medical drugs, and also the other amenities for diabetic patients like the footwears and all those things. So it's also a business. So please don't think that I'm marketing. This is all ideas where we can legally and in a cultivative manner expand our wings. Next is develop an effective community outreach program. After doing all these things, if you think the patients will come to your clinic, they will never come. This mistake we did. So what you have to do is you have to reach out to the community. You have to go to the schools, you have to go to the malls, you have to go to various areas, old age homes, and you have to make yourself a brand for treating diabetes in a different dimension. And you have to bring patients to your clinic. If you have the data of the previous patients who had come to your clinic, for example, if you're running a physiotherapy clinic for 10 years, if you have the last 10 years data, you can just give them a call and you can say that you have started with a diabetic education program, and the first sitting is free of cost, and you can just increase the footfall. Ultimately, in the first 6 months, the increasing in footfall is going to be the vital aim of the diabetic clinic. And once people start registering, you have to charge them on an annual basis. You should not charge them on a single visit basis, because the dropouts are more in our experiment. So charge them on a yearly basis. Okay, and for that, very important is community outreach program, and ensure a spirit of teamwork. And if you can spell this word at the first attempt, I would be very happy for you, because I felt it very difficult to read this egalitarianism. That means giving specific. I think Dr. Ravi Prakash would be knowing this. uh, this word exactly suits this particular team, because in this team everybody has a role and everybody has a value. And if every team member of this diabetic education team respect each other and give their space, this team is going to work wonder. So there is no space for ego or what to say, space given for one particular profession is more and other profession is less. There should not be this egalitarianism should be there in this team. Then you can prosper. And then vertical training, keep updating your knowledge. A physician should teach a physiotherapist should teach a physician, a nursing staff should teach other people how to clean the wound and scar. It is almost like a rehabilitation team where the knowledge sharing is happening and the team meetings are happening regularly. It may sound little odd now, but once you start with the diabetic clinic, and if you get somewhere around 50 to 60 patients, you will find it very interesting to do this. So that is what we have also added Ayurveda into this, because when I say about wound healing, we found that Ayurvedic people can contribute much better than the conventional uh, the allopathic management for wound healing. So we have also included Ayurveda people into this. Invest 20 to 50% of what you are earning initially in improvising the clinic. So don't take all the benefits immediately from this. This is applicable to any business. Don't put every investment into this clinic initially. Just put 50% of what you intended initially, and then by every month, whatever profit you're gaining, just invest 50%, 20 to 50% of the earnings into this, improvising the clinic appearance, hygiene, also increasing the number of workers in your place, and that gives more holistic view to this. Okay, if you are not able to do all these things as a physiotherapist, sir, I'm very busy, I can't spare my Sunday, I'm so busy. Plan B, give this to a contract to a fellow professional. If you have a very good friend of yours who is very trustworthy, who can do this thing on his own, just give your clinic for rent. I have done this to one of my branches, where I have let it out on a lease for one of my friend who was very eager to do this. So you can also contract your clinic for other physiotherapists, preferably. If there is no physiotherapist, you can rent it out for a diabetologist. But this idea is vital. So what are the common obstacles when you're opening a good diabetic clinic? First of all, obstacle what I found was finding out a physician who has a like-minded approach and who was ready to work under a physiotherapist banner. That was a little difficult, but my area is a hub of medical colleges. So my fellow batch, same batch, who belong to my same batch, I found him. He is very cardially good, and we had shared our hostel. So fortunately, he was good enough to be with our team, and he understands the basics, and he doesn't interfere in my liberty. And the laboratory facilities are the major barriers. You should know. You should be very clear and what's precise in whatever reports you are giving. Long-term continuation of the paramedical staffs. These paramedical staffs, particularly the lab technicians and the sample people who collect the samples, they keep shifting places. So that is going to be a big challenge for you. Lack of administrative and peer support. If you are the physiotherapist and if you are the diabetic educator also, you cannot sit in the front office. You cannot do the admin work. So you need someone who has to do that admin work. So please employ a person with administrative qualities, and expect the team, that is the peer, to support you in all ways, and select people in that basis for like-minded. Functionality of a team, increasing footfall is very important. So you should have a community outreach team which always constantly revolves around and bringing patients to your clinic. And lack of egalitarianism, which is also a major flaw. You will find it when the clinic is established and running very smoothly, then you will have the borders being overlapped and the people start fighting with each other. So the famous words from Barack Obama, the former president of USA, pay one diabetic educator $1,000 per month, he can save 10 diabetic patients related expenses, because there everything is insurance. So in case how he is calculating is, if a patient ends up with an amputation or any other complications of diabetes, the US government is going to spend 3,000 to 4,000, 5,000 US dollars per patient. But one diabetic patient who is worth just $1,000 per month can save 10 diabetic patients. So that is the meticulous calculation of best administrator like Obama. So this can also happen in India. So I have done this fellowship in diabetic educator program. 4 sessions have completed. Because of my owing to time and proper platform, the 5th program is pending. My part as a physical therapist, I have educated somewhere around 112 diabetic educators in my career, physically as well as in the web platform. And I'm so proud on this day that I have contributed a little towards my profession in this way. Thank you so much for the opportunity and the time given to me. I think I have abided by the time properly, and also the Pune team and the organizers.
Thane, sir, Thane team. Thane district team, sir.
Sorry, Thane district team.
Yes,
Thane district.
Thank you, sir. Thank you, sir.
Thank you so much.
And now we have a few questions from the audience. Because of time constraint, we'll attend a few. So one of the questions, sir, is what is your take about low glycemic index food in losing weight?
Actually, this is not in the scope of the presentation, but still, low glycemic index, definitely it is going to reduce weight, but how naturally you are going to lose weight by means of going on a fasting. Because fasting is there in our tradition, but fasting is, you can't fast continuously, and low glycemic index is going to make you fatigue, and it depends upon individual. Some people will tolerate, some people may not tolerate. I always believe in a combination of things in reducing weight by altering the lifestyle, incorporating more activity, and eating the correct BMR. Basically, metabolic rate is very important. Based upon that, you have to have your food.
Right. Here it is asked, since it's a task to convince people to come for a diabetic rehab in physiotherapy clinic, how to approach physicians, diabetologists, since from there, the physios get maximum leads, and what are the sources?
Yeah, see, this is a very good question. Initially, I also thought that approaching a physician or a diabetologist to come to my clinic for a 1-day visit or a 2-day visit, I thought it is invincible. But 15 years before, there was only one orthopedician in an area. Now there are 4 or 5 orthopedicians. Now orthopedicians are coming to doorstep of a physiotherapist, advertising and asking us to refer patients for surgery. The numbers not only is inflated in physiotherapy, but also in the doctors are also more numbers now, and the unemployment and the proper recognition is also lacking in their side. But I sincerely tell you, you have to flex your muscles and think about your background, whoever is good, close to you, doctors in all these days. That's why a person who is 10 years richly experienced in the field of physical therapy practice is eligible for a diabetic educator clinic, diabetic clinic, rather than a fresher. So if I'm practicing here 10 years, means I will know who are all like-minded people who will support me. In that way, you have to flex all your muscles, and you have to just find out the right person for your place.
Yes. One last question, sir. Is there any certification or license requirement for setting up a clinic? As you said, lab and all, plus essentials.
Yes, you have some legal procedures for that, which are very minimal, which are not expensive. except for a full-fledged pharmacy, the other formalities are very simple. So that is what we will guide you in our program, how to get the certification for the laboratory, minimal basic requirement of the laboratory, how much a physician who is a diabetologist can store in his consultation desk medications, what are all the medications we can store, what are the bills and vouchers which has to be generated in selling these things on a what is it, domiciliary basis. All these things will educate you when we are doing a diabetic educator program. That is what is very important for you.
Yes.
The operational conveniences of a diabetic clinic.
Okay. Fine, sir. Thank you. Thank you for your answers. And on behalf of the Indian Association of Physiotherapists, Central Team, the Maharashtra team, and the Thane District team, we are grateful to you for sharing such a unique yet need of an hour topic with us and the attendees. Thank you so much, sir.
Thank you, ma'am. Thank you so much.
Now we move ahead with the next segment of the webinar. As the World Health Organization recommends on the long COVID rehabilitation, which should include educating people about resuming everyday activities conservatively, the focus and campaigns from the WCPT for this year's World PT Day is rehabilitation and long COVID and the role of physiotherapists in the treatment and management of people affected by long COVID. And therefore, our Thane team also thought of promoting this campaign initiated by WCPT. I introduce our Thane team member and a well-known and experienced physiotherapist who has been working in the same during the COVID times at various centers. He would share a short talk on the same. Dr. Suraj Shukla, pursuing PhD, in charge principal of B.R. Nath Pai College of Physiotherapy, Kudal, Sindhudurg, MPT in Neurology, certified aquatic therapist by IATF Switzerland, worked as a lead physiotherapist in NESCO Jumbo COVID Center, Mumbai for 6 months, working on providing PT for COVID and post-COVID rehab since May 2020. At present, in charge of COVID Care Center and post-COVID Rehabilitation Department of MIDC Kudal. Over to you, Dr. Suraj.
Thank you so much. Thank you, Dr. Nikita. Thanks a lot, Maharashtra State team, for giving us the opportunity to organize a webinar. And I'm very thankful to the Thane district team, which is constantly supporting and motivating each other. So without taking too much of time, I'll just share my screen. Is my PPT visible to everyone?
Yes.
Yes, it is.
Visible? Full screen?
So please put on the slideshow instead. It will be better.
Okay. So, yeah. So, on the occasion of World Physiotherapy Day, I'm very glad to have this platform of IAP given by Maharashtra State team and also organized by our own IAP Thane district team. So I'm going to talk very concisely and shortly on the theme of the Physiotherapy Day 2021 by the WCPT, which is long COVID and the scope of physiotherapy rehabilitation. So firstly, what are the terms used for long COVID are? The COVID which is being persisting, the symptoms of COVID, persistent COVID-19, The commonly terms used are long COVID, post-acute sequel of SARS-CoV virus 2, that is infection, the SARS-CoV virus infection, shortly known as PASC, post-COVID, also known as chronic COVID-19, also post-COVID syndrome. The definition given by the National Institute for Health and Care Excellence UK is the presence of signs and symptoms, that develop during the that develop during or following the infection consistent with COVID-19, which continue for 12 weeks or more and are not explained by an alternative diagnosis. So the signs and symptoms which we observe in a patient or the patient complains of, we already are aware of these symptoms, because it's been now the COVID-19 also has passed COVID-20 and now we are in COVID-21. The symptoms, most common symptoms we already are aware of, and we are also very thorough, because if any other person says that I have cold or cough, I have chest pain, or I'm having breathless, we start doubting that this might be a COVID symptom and you might have COVID. But here, the long COVID means these consistency of the symptoms for more than 12 weeks, that means 3 months, then they are categorized into long COVID. This includes both the ongoing symptomatic COVID-19, which is from 4 weeks, that is 1 month, to 12 weeks, that is 3 months, and also post-COVID syndrome, wherein the patients are better when they were positive, they had the symptoms, and then they recover, they are fine, and then after a few weeks, that is when they complete 4 weeks, they again start getting the symptoms. But these actually symptoms includes breathing difficulty, hoarse voice, fatigue, confused and distracted state of mind, and blood clot, etc. So, who are these long-term or long COVID patients or chronic COVID patients? The basic and the most important and very commonly categorized symptoms of them are persistent breathing issue, olfactory issues, that is have impaired smell, olfactory the capacity of smelling, it gets impaired, or they have no sensation of smell. Also, who are having taste issues. So internationally, they found that the patients who had COVID, they actually did not get their taste back even after 3 months and 6 months. So this was such a worse situation in the England and European countries. Also, we know that COVID, the patients who have COVID-19 infection, they are endurancely impaired. So they end up in having fatigue issues. Like even a small task or some minimal activity, they feel, after doing a minimal activity, they start finding themselves tired, and there is a fatigue experience in them. Fatigue and also body ache is something which after the first wave, in the second wave, they have started having these symptoms of body ache and weakness. Heavy limbs nowadays, patients who were detected positive after a month span, they find themselves that the limbs are heavy and they are very weak and they are not able to move very flexibly and very smoothly. See, there are these 5 symptoms which are considered to be symptoms of brain fog, which is a term now which has got recognized by the researchers and the practitioners in abroad, that the patients who are having COVID infection, or the patients who were positive, they after 12 weeks, after a span of 3 months, they started finding these neurological symptoms in them, which includes memory problems, confusion, problem finding words, like they confuse, and when they are speaking, suddenly they take a very big pause, and they don't understand that why they are not able to find the word to frame and continue the sentence. Someone might think that this is not a symptom, it's just that some words are out of our not able to get the words to frame the sentence. But they have documented a lot of studies, and in that they found that many or most of these patients who have brain fog issues, they have this issue of finding words. ME and CFS, which I'll be talking in detail further. ME means myalgic encephalomyelitis, and CFS is chronic fatigue syndrome. This is the most important symptom wherein our role comes into picture. And double vision. Also, they have visual impairments. So these symptoms, these five symptoms, these five the complications, we can call them as uh, persisting or developed symptom after the COVID-19. These five symptoms, if it is present in in a person, we call it that they have brain fog. So fog means the blurry situation where we cannot exactly, confusion, problem finding words. These are some of the symptoms which makes the brain in a foggy situation. So here is a study done by the School of Medicine, Department of Medicine in UK. They gave this 50 most common long haulers. Long haulers is also a term used for long COVID patients. According to the frequency or according to the severity of the symptoms, they have categorized and they have sequenced some 50 symptoms, most common symptoms of long COVID, out of which I have just mentioned some 20-25. Which wherein we have to consider these symptoms as the severe ones, and these symptoms are indicating that these patients are categorized into long COVID. So the symptoms are fatigue, muscle or body aches, shortness of breath, difficulty in breathing, difficulty in concentrating or focusing, inability to exercise or be active. These patients after COVID, after the COVID, infection positive, and then after a few span of time, they have this difficulty of being very active or doing any task very smoothly as they were doing before the infection. They have headache, difficulty in sleeping, anxiety, memory problems, dizziness, persistent chest pain or pressure, cough, joint pain, palpitation. There are some less commonly seen symptoms, which includes diarrhea, sore throat, night sweats, partial or complete loss of smell and taste, sense of smell and taste, tachycardia, fevers or chill, hair loss, blurry vision, congested or runny nose, sadness, and neuropathy in feet and hand. This is also one of the things which the researchers and the physiotherapists in international country, I mean abroad, they have found that this is the symptoms they are finding in the COVID patients in a later stage. And reflux or heartburn. Right. These are two studies which I included here. The first study was done in Sweden. They compared, actually the title of the study was Symptom and Functional Impairment, assessed 8 months after the mild COVID among the healthcare workers. So in the healthcare worker team, they had two groups and they divided these groups into one which were having COVID positive cases and the other which were non-COVID positive. I mean, they had negative results. So a total number of healthcare workers included in the study were 300. And post 60 days, they compared the COVID versus the non-COVID. They found that 26% of the positive, that is COVID cases, have more than one symptoms. And they found that non-COVID, 9% of the patients. So even though you are COVID positive or COVID-19 negative, you have this long COVID chances of getting categorized into a long COVID patients group. So after 8 months, they again saw the documentation was continued for 8 months. After 8 months, they found that 15% of the positive cases were still having the symptoms, and 3% of the non-positive, that is non-COVID cases, were having symptoms. 8 to 15 versus 4% said that the symptoms and the problems that they were facing that interfered with the work socially or at their home life. So this concluded that whether you be in the COVID category, COVID patient or no, you have a chances to getting long COVID infection, long COVID symptoms. Now, the other study says that 60-day outcome among the patients, which was done in US, So this was done among the patient hospitalized with the infection of COVID-19. Here, the number of participants were more, and the study was done on a larger sample size, 1,600 subjects, and it was done 60 days post-discharge. So what they found is 33% of the symptoms, they found 33% of the total sample size found persistent symptoms of COVID, and 19% had worsening of the symptoms. And these symptoms included dyspnea with stair climbing. Whenever they climb stair, they found to be dyspneic, shortness of breath, chest tightness. These there are a percentage also mentioned that 17% of the population had a shortness of breath, 15% of them had cough, and the 13% of them had loss of taste and smell. This study was published in the Annals of Internal Medicine. These are the several studies which they reviewed, and the next slide will be speaking about all the findings they found. So here you can see I have taken the graph exactly showing out of those systematic review of a number of studies, like 16, almost 16 papers were compared, and they found that common physical symptoms were 15 to 87% of them were having fatigue, which continues from the first month till the third month. And 10 to 17% had dyspnea, 12 to 44% had chest discomfort, 17 to 34% had cough, and 10 to 13% had no smell, no taste. So these were the common physical symptoms they found in long COVID cases. Some of the neurological common symptoms were PTSD. Now, COVID-19, after the infection, they took it as a trauma. The patients literally got traumatized by this COVID infection. So they had this PTSD, post-traumatic stress disorder in them, which was continued from the first month and went on continuing till the second month almost. And then 18 to 21% have impaired memory. As I told you, these were included in the brain fog. Also, poor concentration, 16% of them had poor concentration, 23% of the total population had anxiety and depression. Areas where we as physiotherapists come into role are cardiopulmonary area. We already know that there was a drastic revolution in the awareness of the people about physiotherapy because of this COVID, and cardiorespiratory physiotherapists, they played a very crucial role in treating COVID infection, even during the COVID and also post-COVID rehabilitation. Now, wherein they had this brain fog and other neurological condition, neurological physiotherapists also come into role. We prevent them by, we already know that in COVID infection, there is something called as cytokine storm, and there is a possibility of blood clotting and thickness of the blood. So these patients are not at all, active and doing any kind of activities. That's why this blood clot might lead into several fatal conditions like pulmonary embolism or brain stroke. So there, our activity, our exercise, our prescription of exercises, we can prevent complication because of blood clot. And of course, the most important part where we are playing role now, also in the long COVID, is the fatigue. So this long COVID and as I mentioned that myalgic encephalomyelitis and chronic fatigue syndrome, which has been documented, and evidence says that this is the most common thing which they are finding in long COVID people. There we as a physiotherapist, we play a very crucial role. But in this, 100,000 of people contracted COVID-19 continue to suffer serious symptoms in the long after initial infection. Similarities between the debilitating conditions were myalgic encephalomyelitis, where the five main symptoms of myalgic encephalomyelitis I've mentioned is reduction or impairment, inability to carry out normal activities accompanied by profound fatigue. So whatever normal activities, day-to-day activities that they were doing properly, easily before the COVID infection, after the COVID infection, even after 12 weeks, they found it to have impaired and profound fatigue, and they were not very smoothly carrying out the normal daily activities, and they used to get easily fatigued. Post-exertional malaise. This is actually when they do a mild activity or any kind of exercise or any activity, any task they do. After that task, they found that these cases started experiencing malaise. This worsening of symptoms after any physical, cognitive, or emotional effort. So it is not only physical; it is also cognitive. If they solving any puzzle, or if they cognitively they use their brain for a longer time in decision making or abstract thinking or any kind of cognitive activity, they found out that they had this post exertional malaise. And also any emotional effort made them feel that this is this symptom was noted. So also the next symptom we found in the chronic fatigue syndrome patients were unrefreshing sleep. Even though sleeping for 5-7 hours, they were not able to find themselves as refreshed, or the sleep was incomplete. Cognitive impairment, as I mentioned about the brain fog, and also the orthostatic intolerance, which means that whenever the symptoms, he or she, the patient has, whenever the person stands upright or whenever does any movement in the standing position, the symptoms it starts worsening. They start finding themselves fatigue, and whenever they lie down, the symptoms got improved. I mean, they got better. So this was related to their orthostatic position. So that's why termed as orthostatic intolerance. Going to the next slide. What are the common where we can document the common measures, outcome measures for assessment and documentation, because to show that we are treating and we are having some kind of change by physiotherapy and by implementing the physical therapy treatment in these long COVID cases, we have some of the common outcome measures, which is 6-minute walk test, time up and go test, short physical performance battery is again outcome measure, which includes some mild activities to moderate activities. FIM and FAM scale, which is functional impairment measures and functional assessment measures. Quality of life skills. MOCA is Montreal Cognitive Assessment. These are most common outcome measures used to document the or record the changes in long COVID. So rehabilitation, this is a poster given by the WCPT this year, long COVID and rehabilitation, in which they mentioned that long COVID is a different for everyone. It might not be the same. And a physiotherapist can help you manage your long COVID symptoms. How? Activity management or pacing is likely to be a safe and effective intervention for managing fatigue and post-exertional symptom exacerbation. So this exacerbation means whatever they exercise, whatever activity they do, after that they find that the symptoms increase. So PESC is one of the things which we manage if we design the activity and implement pacing in between, so we can have a safe and effective intervention on PESC. Heart rate monitoring is likely to be a safe and effective intervention for managing fatigue. So whatever exercise we are designing or any activity, we have to constantly see the heart rate, which can be one of the safe and effective intervention. Graded exercise therapy should not be used, particularly when post-exertional symptoms exacerbation is present. When PESC is present in these long COVID cases, we should not grade the exercise, or we should not give any vigorous physiotherapy in that case. Also, again, exercise prescription in long COVID plays a very crucial role. How and what we have to prescribe in long COVID depends on the symptoms and complaints of the patient. It should be approached with care to minimize the risk and ensure the exercise programs are restorative and do not make individual symptoms worse. So whenever we are giving any exercise, if the patient says that my symptoms are getting worsening or I am finding myself more fatigue, we don't have to give that exercise. We have to design it in such a way that it prevents the oxygen desaturation. If we are not able to, we put the pulse oximeter to the patient, the COVID treatment, we see that the oxygen is saturation is improving by therapy. But when we find that whenever we are giving any activity and the saturations drop down, we have to prevent this desaturation. So we do not have to give any vigorous exercise or any straining or graded activity. We just have to prevent the desaturation in these patients. A specialist of respiratory physiotherapy may help where there are signs of hyperventilation and breathing pattern disorders. So our cardiorespiratory physiotherapists who are specialized in cardiorespiratory conditions, so they can help the patients here to where there are signs of hyperventilation and breathing pattern disorder. So graded exercise again should not be used, particularly when PESE is present. So wish you all a very happy World Physiotherapy Day from my end, and thanks a lot for this platform again. And I'm really thankful to the super supportive team of Thane. Thank you.
Thank you, Dr. Suraj. And here we come to the end of this event. And now would like to request Dr. Venkat Ramesh Sir, convener, Thane district team, to give a vote of thanks to us.
Good evening, everyone. And I'm here to present the vote of thanks for today's webinar. I'd like to thank our guest webinar speaker, Dr. Arunachalam Sir, for visiting and enlightening us with his knowledge. Today's lecture webinar was full of knowledge and interesting things. It gave deep insights to the topic and revealed some interesting facts also. The point where Dr. Arunachalam was telling about the diabetic clinic was really informative. I am pretty sure his precious knowledge and will definitely help us for our studies and for future setup also. And also I would like to thank Dr. Suraj for taking out time in his busy schedule and enlightening us with his knowledge. Thank you so much, Dr. Suraj. And I also like to thank our central team dignitaries for giving permission to organize this lecture and webinar and inviting our guests to conduct it. So special thanks to our IAP central team, Dr. Sanjeev Jha Sir, Dr. Suresh Babu Reddy, Dr. K.M. Annamalai, Dr. Ruchi Vashne, Dr. Joji Jan, Dr. Nehal Shah, Dr. Sudeep Kali, Dr. Achal Vashi, and also a special thanks to our Maharashtra state team, Dr. Ujjwal Yevle, Dr. Amit Gire, Dr. Bharti Dev, Dr. Darshana, Dr. Mansi Mehta, and all the EC members. And a very, very special thanks to the IAP digital team, Dr. Uttara Mohan ma'am and Dr. Manisha ma'am. You have really helped us a lot for the digital coordination of today's event. I also wanted to give a special thanks to our IAP Thane team committee, who really worked hard to make this event very, very successful. And also thank you to all the participants present here for paying your attention and learning. Thank you so much. Thank you.
Thank you all. Hope we meet soon for the next upcoming events organized by IAP Maharashtra State Thane district team. Thank you. Have a nice evening.
Thank you, Dr. Nikita. It was a lovely session, and we'll end this session now. Thank you so much.
Thank you.